I'm Franco Recchia. I'm a retina specialist in practice at Tennessee Retina in Nashville, Tennessee. We are a private practice, retina-only regional referral group. I originally trained at Wills Eye Hospital and Associated Retinal Consultants, and was on faculty at Vanderbilt University for 8 years, where I directed the Retina Fellowship and also directed the Retina Division, participating both in clinical and laboratory translational research. More recently, I have focused my efforts on clinical practice and clinical research.
Please tell us about the research you presented here at AAO.
So here this year was a study looking at real-world patients in a practice setting with neovascular wet macular degeneration. Just let's take a step back and think about the explosion in data and informatics that we've seen in the last decade. We hear a lot about big data. We hear a lot about patient outcomes. There's been a big push through independent registries, third parties, and our academy as well, with a wonderful registry of real-world outcomes. The goal of these studies in general is to see how our patients in practice at an everyday level do. It gives us the 30,000-foot view that is impossible in a small practice setting. Historically, we would do studies of a retrospective nature looking at a small group of patients from a single practice or several practices, but that was limited. It was limited by numbers, it was limited by geography, it was limited by time. With the explosion in big data and registry acquisition, there is an opportunity to query hundreds or thousands of patients from across a nation or even across the world. But the double-edged sword of that is a lot of background noise. And we have to be careful that we tease out the quality, but are also cognizant of some of the pitfalls of these big data approaches. Specifically for this project, I wanted to make sure that the conclusions that have been proliferated about clinical outcomes in macular degeneration based on big data were accurate, or at least are tempered with good methodology. Let me explain what I mean. Clinical trials remain the benchmark for evaluating clinical outcomes, as well as for achieving approval of new medicines, as well as serving as benchmarks for how patients and physicians should do. They also serve opportunities for unmet needs. They also serve as opportunities for new research projects. Over the last 5 to 10 years, numerous studies of quote-unquote real-world patients have virtually all concluded that in clinical practice, patients do not do so well as they do in their clinical trials. In other words, it appears that clinical outcomes are inferior and patients are undertreated compared with what we would expect based on clinical trials. And I think one possible reason for that is that we're dealing with different populations. So the analogy I use is going to a bakery that sells apple pies, and they make their pies with only 100% apples. The bakery next door also sells apple pies, but they mix in some oranges. The pies probably won't taste the same. You're mixing apples and oranges. That was the metaphor for the mix of patients that we see in daily clinical practice in a real-world setting compared with the mix of patients that are seen in a clinical trial. clinical trial is the best case scenario. It is patients who have a certain clinical profile, they have a visual acuity of a certain range, they've never been treated before, they don't have, they don't have other health problems. Anatomically, they may be more apt to respond to treatment. They're also more motivated. They have perhaps the awareness or access or desire to maintain their follow-up visits and their treatments. So the question we asked was, in a real-world setting, how closely do our patients actually resemble the patients seen in clinical trials? Because maybe clinical trial patients perform better, maybe real-world patients, quote-unquote, underperform or undertreated simply because they're very different populations. In an era where physicians may be evaluated on their outcomes, or where health dollars need to be allocated based on needs and resources, it's important that we know exactly what kind of patients we're treating, and not just assume that the patients in our offices on a daily basis reflect the ones seen in our clinical trials. What we found was, in a consecutive series of patients with wet age-related macular degeneration, more than half of them would not even qualify for these clinical trials that inform our care. In other words, out of every 10 patients, 6 of them would not have the qualities or profile or characteristics that our clinical trial patients would have. So we have to hesitate to assume that a patient who doesn't reflect a clinical trial profile will have the same outcome as one who does. Again, a pie made with 100% apples is probably not going to be the same as a pie made with half apples and half oranges. Specifically, we found that most patients would not be eligible because of characteristics of their disease. For example, they had atrophy or fibrosis involving the fovea, which we know is vision limiting. Some patients had already been treated. Some patients had other comorbid health conditions. All of these factors would probably lead to a suboptimal outcome compared with the clinical trial patients. Many of these conditions would also result in a patient not being treated as frequently as we would have seen in a clinical trial patient study. We took it one step further. Once we had separated what we called the real-world clinical trial eligible patients versus the real-world clinical trial ineligible patients, we asked a simple question: how did those two groups do? And overall, it is true, they did worse than what we would expect in clinical trials. Taken as a large group, as a big real-world group, they do achieve less visual acuity gain. They do receive fewer injections of anti-VEGF medications. But if we split that group out into the trial-eligible patients and the trial-ineligible patients, then we see a big disparity. In other words, if we look at our real-world setting and we identify those patients who reflect the clinical trial patients, the outcomes actually are pretty similar. They achieve visual acuity improvement that we would expect, and they are treated with an equivalent number of injections. Those patients who are ineligible for whatever reason, prior treatment, poor visual potential, scarring, atrophy, those patients expectedly don't do as well. They tend to be treated less than expected. But again, they're a completely different group from what we would expect in clinical trials. So when we compare apples and apples, it seems, at least in this study of our group of over 500 patients, it seems that our outcomes were actually pretty good. We also show that the difference in outcome, the quote-unquote under-treatment or the less than expected visual outcome, may be driven by a large group of patients who would not have been in that clinical trial group to begin with. So when we just look at our pies made with apples, they taste pretty close to what we'd expect from the 100% apple pie bakery.
How does this research give patients a more realistic view of their treatment outcome?
I think that's a great question. Certainly, we can use this information to help our counseling in the patient sitting in front of us. It's nice to be able to quote the expected results based on well-done clinical trials, but as much as possible, we would like to tailor both the expectations and the treatments to the individual characteristics of the patient, and that's a big disconnect. One way this research can be helpful, and I would love to see it augmented and replicated by other groups, would be perhaps be able to stratify patients, not just as one big group of real-world patients, but stratify by groups of patients according to visual acuity, prior treatment, other comorbidities, and maybe give a little more precision or a little more accuracy and clarity to a patient with those specific limitations. For example, while overall a patient has about a 40% chance of improving vision by 3 lines or more in a year with on-label regular injections, probably about half of patients cannot expect that. And it's, I think, important and just honest to try to figure out which half a patient may fall into. The other way I think this research can be helpful is to remind our researchers doing these big data studies of a limitation of some of those data sets. So either acknowledge that limitation and try to account for it, or include such information up front when we're ascertaining these patients and identifying their outcomes. One limitation is that the granular data that we are able to achieve on a patient-by-patient, chart-by-chart basis in a large practice such as ours is not often duplicated to that level of detail in a large registry. But some of these details are crucially important, as we've shown. We have similar projects going on for other disease states, such as diabetic macular edema, retinal vein occlusion. Those characteristics of inclusion-exclusion from clinical trials may be more readily identified from registry data or from big data sources. And again, this same research algorithm can be applied to pretty much any disease of interest.
So do you have any next steps in this, or was this your...
What are your next steps in this line of research?
Next steps for this project for wet macular degeneration are really two. One is we've expanded our analysis to go beyond 1 year of follow-up, where we now have 2 years of follow-up, including a larger set of patients. So we now have approaching 1,300 cases, and we have 2-year follow-up now on the majority of these patients. The questions we can then ask is, do the outcomes hold up at 2 years as they did at 1 year? Do our treatment patterns change at all after 1 year? And again, these projects are mirroring some real-world projects that have been done using large healthcare databases, meant to show two things. We're trying to show that there may be a disparity in these outcomes because of different populations involved. We're also trying to show that we need to be, I think, a little more scientifically rigorous in our methods before we make sweeping conclusions about our patients being undertreated or not achieving desirable outcomes.
Where can we follow you and your research?
Yes, certainly any interested parties can contact us at our practice address, TennesseeRetina.com, www.tnretina.com. These findings have also been presented at national meetings, which are available online and will be published hopefully soon in the peer-reviewed literature.
Thank you for joining me today.